All right, everyone. Hello and welcome to our journal club for February. Vestibular First. Happy to have a very special guest with us tonight, Dr. Susan Whitney, very expert in her field, research, education. We're so happy to have you and just like to hear a little bit more from Dr. Whitney about yourself.
Sure. I work at the University of Pittsburgh um, outpatient neuro center within Eye and Ear, and I am a full professor at the University of Pittsburgh in the program of physical therapy. Got my degree at my final two degrees at the University of Pittsburgh, and I'm a Temple University graduate.
Awesome. Well, here on the outskirts of Philadelphia, we're always happy to have a Temple grad with us as well. Many great therapists have come from there for sure. Um, so, tonight's topic, we're very excited to discuss the physical therapy treatment, specifically vestibular physical therapy, of individuals exposed to direct energy based off of an article. Kind of discuss that in detail here that you were a part of publishing. So, we're really looking forward to your insights on that. So, let's go to our slides and we'll talk through this case here. So, before we talk about the article, which was so well written, we're going to get a little bit of background to make sure everybody's on the same page about some of the terminology in the paper, because some people may not have the same background as others. So, one term we want to define is electromagnetic radiation, both ionizing and non ionizing, and directed energy, and what those terms mean. So, electromagnetic radiation, people might have had a physics class, maybe reaching back in your memory. For those of us who've been a while since we were in school, um, we're looking at some sort of radiant that's kind of considered light. And we think of light as something we can see, but of course, there's visible and invisible light, depending on the wavelength. And traveling in waves at a constant speed, carrying energy, which has electric and magnetic fields varying within it. So the types of electromagnetic radiation that exist, one would be ionizing, which means it could cause damage to the DNA. And an example there is very powerful gamma rays, which they actually use sometimes to treat cancer, for example, to kill the bad cells. And then there's non-ionizing radiation, which can be important to life. For example, photosynthesis relies on this, our classic visible light. And that's not necessarily damaging, but it can be if it's too intense, right? So there's kind of a whole host of considerations there. And then directed energy, specifically, the focus of this article, is a term that kind of covers different technologies that relate to the production of a beam of concentrated electromagnetic energy, or particles of some kind, atomic or subatomic. And that sort of energy, again, could, in the wrong amount, we'll say, or intensity, could potentially cause some sort of damage to people. So, directed energy, as described in the article, they say, exposure is a phenomenon that's been reported in Cuba and China by both U.S. and Canadian government employees. And the symptoms that the Department of State employees experienced were similar to what would be expected after exposure to directed pulsed microwave energy. Now, I was going to ask you, in that regard, do you think that's based off of kind of a mix of studies, maybe some animal studies and things like that, or do you know kind of what that background is? I can't hear her.
My apologies.
That's okay.
I It's based on both. There's some animal work that has been done in the 60s and 70s, and also human work, but mostly animal work that seems to suggest that this kind of energy could cause damage to humans.
Got it. Very helpful. All right. So they also, in this article, define the Frey effect, which is kind of a microwave auditory effect, producing pressure, dizziness, and sound, such as knocking or buzzing in the head after exposure to radio frequency energy. And apparently, this can occur in both hearing and deaf persons, as stated in the article. So I was interested in those microscopic photographs you can find online. And I found this one that's showing intact and damaged auditory cells specifically, but we know vestibular um, hair cells can also kind of look like this, perhaps when damaged. So what I'm looking at here is that there's different types, according to the article, or categories of potential effects of this sort of energy. So damaging hearing structures, damaging other cells, I guess, or kind of creating some other effects to the sympathetic nervous system. And then kind of non-hearing effects such as pain, vertigo, nausea, and vomiting. So do you know the work of Wachem and Cook? Did you look at that since you referenced them at all?
We did, yeah, and it was interesting because the gentleman that the case revolves around, his hearing was normal, but that's not always been true in others, especially many of them experience tinnitus. That's a pretty common complaint in the folks, especially the Department of State employees.
Very interesting. Okay. So, quite unfortunately, we always wish we had more science and we're working on it, right? But there's no standardized methodology for testing exposure to directed energy, which is part of what I think seemed to me make this a challenging case. And the typical symptoms, that are kind of reported, it seems, resemble mild traumatic brain injury, and you go into more detail in a very nice way in this article. Dizziness and balance for some people, headache for others, visual complaints, cognitive defects, or deficits, difficulty with sleep and anxiety have been reported. So it sounds like when you look at broader groups of people that it can vary. Is that correct?
That's what I understand because there's very little written up about individual people. Our case was the first about one person. Most of the studies to date have, all the studies to date have really been aggregate data. So you really don't know how many people have each symptom. And they're doing that obviously to protect people's identities.
Absolutely. No, that makes sense. All right. So again, going back to the article, the purpose was to describe that individual exposed to directed energy and their case, and offer recommendations to benefit future diplomats and government employees who might experience some of this same kind of symptoms as a result of directed energy exposure. So here we have our patient, which you described very well in the article, 43-year-old male, working in China. Onset of symptoms was now, I guess that's 5 years ago, if my math is right, give or take, 4.5. And you describe this kind of like report of this kind of specific sound, and I didn't get into typing all that out, but there was some mention here and there of the individual's wife having a similar experience. And I think that seems to be relevant to me to kind of, not that we're trying to distrust, right, the report, but it's nice, when you kind of have two different people saying, yep, this is what I experienced. Is that right?
That's exactly right. So they both had very similar experiences, as did somebody else who lived near them.
Got it. Got it. Consistency. Okay. So this individual came back to the U.S., if I understood the article correctly, and they decided to do some different treatment recommendations. So some of them were nutritional, right? So this magnesium, riboflavin, and then something for the headache, right? The amitriptyline, and then some therapies. So just for a moment, I know that you weren't necessarily directing care for this person, but do you know kind of what the rationale was for some of these different recommendations?
Well, I know the magnesium clearly was for his migraines.
Mm-hmm.
So they were trying that. And the Alavil can obviously help. It can help with depression, but can also help with the headaches too. So that's why he was on that. I don't know why they tried the riboflavin though. Yeah, and it's not uncommon, and there's more and more literature about the cognitive behavioral therapy being helpful because he really does have symptoms, and some of the other persons that have been exposed to this directed energy also have symptoms that are similar to concussion,
Mm-hmm.
and we know that cognitive behavioral therapy it helps with that, and also with in conjunction with vestibular rehab or dizziness that we typically treat.
Absolutely. No, that does make sense. And then one of the growing areas of literature that We see a lot is, of course, the daily physical exercise. That's something I have seen lots of literature on, at least for concussion. So again, that kind of makes a lot of sense to me, for sure. All right, so we talk about the exam a little bit in this section of the article, the sensory organization test, with some difficulty on conditions 4, 5, and 6. Convergence would be considered abnormal, since normal is 5 to 7 centimeters, correct?
Mm-hmm.
Mm-hmm. And then
Usually under 6, but yeah,
right.
depends on what you read.
Depends on who you ask, exactly. well, welcome to different courses I've been to, right? It's like, all right. But yeah, and then the symptoms, right? So we're looking at some nausea with pursuits and fast VOR and the head shake, nystagmus test. Can you speak to, kind of if you think that parallels with concussion findings or what that looks like for the folks out there?
It does, but not all persons with concussion are going to have difficulty with the sensory organization test. But, since I wasn't there, I do see people who are really prone to migraine, that they actually can get motion sick when the posture platform starts to move. So you don't, since I wasn't there, I don't know, but that's another possibility there.
Okay.
But to me, this is a guy who's an athlete, and when I see red on somebody who's an athlete who's 40 something years old, it just doesn't make sense.
For sure.
It's definitely not. I mean, overall, if you look on the far right there, it's green, which suggests that he's quote normal, but I don't really consider him normal based on looking at those scores there.
Right, and I agree, and I think that speaks to kind of different, what we'll call ability levels, and kind of what his theoretical baseline would have looked like, most likely, which I think we can both probably guess would have been quite different on those, final 3 conditions before this incident, it seems. And what about the pursuit? Right. Go ahead.
No, I was just going to say nobody should get nausea or head movements. Now, I do see people who are real motion sick if they're migraineurs before that the head shake test can cause people to be nauseous.
Mm-hmm.
But VOR times 1, not typically, and definitely not pursuits.
Right.
Those are very unusual, especially the pursuits are really unusual for somebody to get nauseous with that.
Unless concussion.
Right.
Right. Got it.
But even then, it's more the VOR times 1 or the VOR cancellation that really bothers me. Or the smooth pursuits are pretty low on the list in terms of making people symptomatic.
Got it. That's good insight.
My impression, anyway.
Yeah. No, I would. You have more experience than I do, but I would agree. Yeah. So they did mention that mild motion sensitivity with the VOR cancellation. So you alluded to that. And the dynamic visual acuity, loss of 3 lines to the left and 8 lines to the right. And for those of us who have not used an instrumented device, can you kind of talk a little bit about what that normally looks like, what that test is like, if you're not doing it kind of the traditional way, which is no instrument?
Right. So it's really a great test. And we use it a lot with our persons with concussion, and we've published several papers using the either dynamic visual acuity, or we use the gaze stabilization test. And the whole idea is to see, can you move your head and see the target, right? And what is really interesting with him is that he's so different on one side versus the left. And that is not typical, but he can go at a fairly decent clip, up to 120 degrees per second. We just finished a project. It's only with an N of 4, but we looked at how well people could keep their head, maintain speed at 80 beats per minute, and it's really easy for most people to do that, but not so easy at 120. So the speed there is good, but the fact that there's asymmetry really gives you an idea that something is definitely off here, because most people are consistent to both sides. And that's right. The nice thing about this. When you instrument it, you can actually figure that out, that there's a difference, right versus left. Clinically, you come up with one score.
Got it. Now here's a question. If you have someone with a hypofunction, are they kind of imbalanced that way? And is it typical for someone, say, with concussion to be imbalanced that way? Or what is your experience with that specifically?
That's a good question, and I can't answer that well. I can tell you that I've got some recent evidence, at least, that with unilateral loss, there is an asymmetry
Mm,
that I can tell you, and you can pick it up with a device like this. But with the the piece of paper that's on the wall there that I use in the clinic too,
yeah.
you can't pick that up.
No, for sure, for sure. No, and that's how I do it as well. Is the I don't know if you want to call it the old school way, but that's I don't have instruments, so yeah, I know what you mean. So it's very. I'll be interested to see what literature. Maybe I'll do a little search on my own, but if they have any on kind of different diagnoses and if they present a certain way on the instrumented, that's an interesting kind of point to ponder. Very good. All right, so treatment wise, the article describes some eye tracking invergence exercises, a Brock string situation there, gaze stabilization exercises, which would make me think VOR times one and that sort of thing. Some tinted lenses were recommended later on during the course of care, some lighting adjustments, um, cognitive therapy. Looks like there was some follow through on that, and the balance exercises were reported once or twice a week. And the article a couple times mentions kind of the inconsistent nature of kind of being able to follow up with this patient. And I don't think it really says why, but I'm going to guess maybe just the person was busy working, whatever it was. It's not like they were seen, once or twice a week for so many weeks straight, like in the clinic for, a very specific amount of time with a specific therapist. Am I interpreting that portion correctly?
Not really. What was happening, and that's why the Department of State has changed their protocol for these persons, is that um, they were searching for help and nobody knew what to do for them.
Mm,
And as a result, they ended up getting not so great care. And the Department of State has changed their protocol and is definitely fixing it, which is a
that's
blessing.
That's wonderful. Yeah, I mean, we learn through our experience one way or the other, hopefully. So,
Mm-hmm.
so there was some care at least provided. We see that described. So that's good to get something there. So again, they kind of follow up assessments. The sensory organization test is showing improvement. That's reported that the person was able to resume running and did some cross country skiing. The FGA was topped out, which again, like you said, for an athlete, even if they're recovered, is not unusual, but maybe they're still having some symptoms, right? Um, and you do a nice description at the end of all the different other possible ways to track symptoms. So we'll talk about those shortly. But the BES scored well at that point, and they talked about an MRI, and I think it popped into my head. Was that the first MRI at 9 months? Do you know, or were there others, or that showed normal, or do you have any idea on that?
That's a good question. I don't remember, but I know he did some DTI work too. So he went to another brain expert to try and figure out what's wrong with me, and they did see some changes or some perceptions of changes of tracking within the brain, but there might be some damage there too.
Got it. No, and I think what's tricky when I tried to kind of look into this kind of foci and what that can mean, it basically said it's pretty non-specific. It doesn't mean that there isn't an issue, but it's not like some sort of clear-cut huge tumor or something that we were like, oh yeah, that's an issue there. It's apparently somewhat common in people with migraines, so that's what I read. Is that your understanding
Hmm.
as well? Okay,
Yes,
so
definitely. Well, it's hard to tell, what was there before, what's after, and that's part of what everybody who has had this problem is dealing with. What was there before and what isn't? Well,
makes perfect
wasn't.
sense. Right, right, absolutely. All right, so then we have a year out report here, talks about some symptom issues using the computer and some adjustments on medication there to address the headaches. Um, and then 2 years out, kind of some more symptom reports that are a bit different and some findings that are a bit different. So I was interested in this kind of, I believe it was this, they used SyncThink, if I'm not mistaken, and finding some impaired saccades or something like that. What is your understanding of that testing?
Yeah, so this was another fancy test, but the thing that was fascinating to me is that they identified the same problem to the right. Everything was to the right. So the dysmetric saccades are unusual. And, like a year and a half, 2 years apart, you see the same thing. So to me, it was very validating that he has a physiologic problem.
Definitely. And when any patient, which I'm sure you've known a few yourself, who kind of is going through something that's not clear cut, right? Again, not that big tumor that everyone can be like, oh, there's the problem, right? And it's kind of more this variable symptom levels, probably, and things like that, depending on, oh, I can work on the computer this long, but not this long, and that kind of thing. And I know that for my patients with concussion who have prolonged symptoms, and I think this is mentioned in the article, the impact of things like stress or sleep and kind of how that can vary someone's presentation and how they feel on a given day. It just feels a little more challenging, right, than somebody who has an obvious problem with, these kind of clear-cut findings. And so that's very interesting to me as well, that right-sided finding there. So it looks like the person was offered some apps and games for concentration and for saccades and smooth pursuit. So I realize that, hindsight's 2020, but let's say that you had this patient at this point and you hadn't seen them prior. Is there anything else that you might have thought in the sense of treatment for this patient?
Well, with what I knew then, I'd probably, well, if it was now, I'd think about doing the VUR times one with virgins to see if that would help too, to see if I could increase the gain that way. Um, a lot of the things that were done here at this point were more for habituation, but um, I think I'd probably pull in somebody, a neuropsychologist, and work on some of the cognitive behavioral um, issues too, to see if that plus physical therapy could really help him. He was running, he was moving around, but he still was highly symptomatic, and we can't quite figure out why, but it's probably this problem that he has moving his eyes to the right.
Absolutely.
And how do you solve that?
Right, right. And I think that's also, I think we talked about this a little bit with athletes. It's tricky because people you look fine, right? The whole look fine. I know a lot of patients have complained to me about this as well, as far as like even their family members, like understanding, like, okay, I look fine and I function okay, but I'm still feeling this, or, I can only do this many hours on the computer and before I could do forever, and just kind of the person knows that differential, right? So functionally, they're feeling that, even if, yes, they're not falling over the second they get up, that's great. But, right. So it's all kind of relative to what the person's expecting and their prior level of function for them.
And he's still only working half day. So he's not right.
Right. No, that's not where he wants to be 2 years out, right?
No, not at all. It's a shame.
For sure. For sure. Well, learning as we go, as we say. So they looked at him 2.5 years out, according to the article, and quite an extensive series of assessments here. So I do want to talk through these because some of them were unfamiliar to me. And I figured that there might be a few that some people who are watching might not be as familiar with either. So one that I was familiar with right off the gate was the Dizziness Handicap Inventory, which at this point, pretty far out from the initial event, was considered mild, so not zero, but mild. And I wondered if you had any insight for those who are not familiar with the different subsections, the physical, emotional, and functional, kind of what that meaning that you might draw from something like that, kind of breaking it down that way.
Well, if they're high in physical and low on the other, then a lot of movement usually gets them better. When the emotional and functional are a little higher than the physical, then it may be a little bit more challenging. This is a chronic case. He's carrying some emotional baggage with all of this, and he's still impaired, and he feels it. So it's no surprise. If he were really bad, there's a recent paper that Jeff Staub just published with his group from the Mayo Clinic that states with the DHI, if your score is above 60, you definitely have some type of psychiatric diagnosis. There's something not so, you've got some big time issues when you see DHI scores that high. He's nowhere close to that. So this is a guy who's really, I think, adjusted incredibly well to what is now a chronic condition that he's trying and seeking help for to try and improve his function.
No, that's a very good point for sure. And it's good for us to keep in mind. I think sometimes the DHI, oh, it's something I could use as like an outcome measure, and that's good. It's not that it's bad, to try to look at how we might try to improve that number, but I think the details behind it sometimes, and making those considerations, and thinking about what this article mentions, and what we hopefully strive for all of our patients, is this kind of concept of multidisciplinary approach. And some people need more of that than others. Sometimes it is a nice, happy, simple BPPV that we clear and send them on their way, and you don't necessarily need any other major interventions. But not everyone is so lucky, such as this
Right.
patient here, right? So I think looking at things like, other value of that number is a very good thought for those who are listening, to kind of what else might I be recommending, and pointing people towards resources, that could benefit. So another measure was the Vestibular Activities Avoidance Instrument, a 9-item. So that one is not one I've used personally, and maybe you can give us a little insight as to what patients you think, whether their presentation or diagnosis or both, benefit from being assessed in this way, or kind of trying this with them.
Well, the VAI, we've published 2 papers so far. Dr. Dunlap, that was her dissertation to get this work out, and she's done a great job of it. And we've got another paper that is inches away from being in press that came out of Belgium. It's really similar to the fear avoidance beliefs questionnaire. That's how we developed it. And what it does is it fairly well predicts whether they're going to be better at 3 months. And if you were to use it acutely, we're going to get those numbers hopefully out there. If you use it acutely, what it can do is give you an idea of whether they need more care. And that's what I wanted to, we're starting to talk about personalized care, precision medicine. And what we need to do, just like with back pain, because dizziness and back pain are so similar in many ways, what we're trying to do is figure out who are the people that need more than you to get them better. And if we can identify those people acutely, what we can do is, I think, decrease downstream costs. And that's what they do with back pain. And I think we need to be doing the same thing with persons living with dizziness disorders.
I think that's brilliant. So if you could think of the top 3 providers that might need to be on a team of somebody who scores in such a way that you think they'll need that support, kind of what would you say are on your roster, or people that you would want to, disciplines will say, that help support these kind of patients?
Sure, like a psychologist or a psychiatric nurse practitioner, maybe a psychiatrist. I think those are the kind of people who can help move the person from kind of this tenuous acute stage where they could go either way to hopefully lead to a quicker path to health and fitness.
Got it. Got it. Excellent. No, I think that's really great. And I think that, which talk was I at CSM just recently? It all kind of blends together in a positive way. But someone was talking specifically about the idea of, a goal of Dr. Stobbs, who you mentioned there, was that, it would get to a point where 3PD, persistent postural perceptual dizziness, does not exist, because, when someone has something, usually an acute incident of vertigo of some kind for some reason, from a pathological sense, that, someone who says, oh, this person needs care, and they get the right care, and they get the right support, and if they need, some sort of psychiatric support at that time, or, close to that, that can kind of possibly minimize or head off a more persistent dizzy state. So that seems like that's exactly what you're talking about. Is that right?
Absolutely. And that's also, if you think about back pain, that's the difference between having chronic back pain that they never seem to ever get better, versus those people who adapt quickly, get care quickly. Because we know that if you're seen within a couple days by a physical therapist or a chiropractor, after back pain, that those people get better a lot faster.
Right, right. And, when we're educating our patients who do seem to be in that 3PD boat, talking about it being a learned dizziness is kind of how I say your brain feels like that's how it's supposed to be now. And so, the idea that our brains are learning machines is what I like to also say to my patient, which makes me also say, hey, it can also unlearn it, or we can change that, so that's like my positive spin at the end. So we can hopefully move forward. But, obviously the sooner the better we intervene is kind of the point here. And if it's a few months out, that's better than a few years out. If it's, so you're trying to kind of as soon as you can. Does that seem like right?
Yeah, there's fear avoidance in people with vestibular disorders, just like there is with back pain. We need to kind of get that quickly, and if we do that quickly, well, and there's the two LaCour papers that came out within, I think, 2019 and 2020 or 21. That even with acute unilateral loss, that if you see people within the first 2 weeks,
Mm-hmm.
their VO gain is much better, and they
Mm-hmm.
actually have much better results. So it's very clear that like back pain, the sooner we get them in, the better off they're going to be.
And that's an education piece that I think that hopefully all as vestibular therapists we're working on with our referrers, if you will, and the community in a larger scale as well. To understand that it's not let's just see if your dizziness goes away and right?
Right. Yeah, I think we as physical therapists need to do a much better job educating physicians about the fact that acuity does matter.
Mm-hmm. Good. Sounds like a whole series of community/physician educational PowerPoints should be put together as directly after this journal club so that everyone goes out to their local communities.
Mm-hmm.
Yeah?
Definitely.
Sounds like a good October physical therapy month project that I can try to put together. All right, we'll move on to the next of our assessment scales here, the activity-specific balance confidence scale. I was familiar with this one. What I'm interested in here is, do you feel it's valuable to look at the specific items that a patient might score themselves particularly low on?
Oh, right. Of course, because, like who isn't afraid of walking outside on the icy sidewalk? I mean, I did that this morning and slipped twice when I was out walking at between 5 and 7 a.m. That's a reasonable thing to be slightly fearful of. Yes, so I do think it's important that you take a look. If they say they have trouble reaching for an object off a shelf at eye level and they say that's a problem, then that's a pretty darn significant issue there. The check does make a difference, of course.
Absolutely. And yes, I actually do worry when someone scores himself 100 on everything in that sense. Like, I'm like, oh, you're 100% confident on ice, unless they're an ice skater, in which case I'm like, okay, that makes sense. um,
Right.
yeah, but I'll have some folks who I'm watching them walk in with their cane looking pretty unsteady, and they score themselves 100 on all of those things. And I'm like, okay, maybe insight's not totally with us. Which is
Hmm.
important, right? I mean, we know fear of falling makes people at risk for falls, but I do think, from a safety judgment standpoint, right, we have to think like OTs maybe a little bit, put our OT hat on and say, okay, what's going on there? I know.
I would see, does reality match their perception, which is exactly what you're saying.
It's not something to be ignored, but for this patient, it seems like they probably, had a little bit of a hesitancy, and I think that's showing here. That makes sense to me.
Mhm.
All right, now the Falls Efficacy International Score. This was definitely new to me. Can you tell me about the value of this? Who do you think might benefit from a screening like this, or what's kind of the benefit or use case that you see for this one?
Well, I can't remember why I gave them both, but the FESI is, we actually validated that and compared it to the ABC, and they correlate pretty well in
Great.
persons with vestibular disorders. But they asked different questions.
Hmm.
And so I wanted to be comprehensive with him, and he was more than willing to fill out all the questions that I asked him. So I gave him that one just to see. But it does correlate very well with the ABC. So if you were to do it clinically, you would choose one or the other, but not both.
Got it. Got it. And maybe time, because this one seems a bit shorter than the ABC. And I
Yeah.
personally liked that it was very ADL focused in a sense. So if a patient or a family member maybe is reporting a bit of that anyway, it might be nice, either from goal setting or just kind of really focusing in on that person's situation. If they're more at the home, some of those things, and the other, the ABC might not apply, or be. So that's an interesting way to think about kind of using one or the other depending on what's a good fit. And I think that's a good way to think of outcome measures sometimes in general, because I'll have students coming and they're either like wanting to do everything, or they are like, I don't know which one to pick, or they like, I know this one, so I'm just going to do this one forever, all the time with everyone. And I'm like,
Yeah, that doesn't always, one size doesn't fit all, and that's what personalized medicine is about. We have to start to think about what's the best for the person. What's the best measurement tool to use for the person in front of you? Now, that's absolutely opposite what the Neurology Academy is saying. So they're saying that, well, not exactly. But, there's the standardized measures that they'd like us to all do so we can compare data, and I agree with that. But beyond that, and I think they'd agree too, there are specialized tests that you need to do for specific people so that you can look at measurement outcomes that you're working on. And if you don't test them, you're not going to know whether they got any better on those things. So I think that part's important. But there are some standard tools that I think all of us need to use on all of our patients. And the Academy, I think, has done a wonderful job with it.
no, I agree. And I think the fact that they've tried hard to, support the measures that seem to have the best
Mhm.
validity and, all those kind of things that we should be caring about. And just because the scale
Yeah.
exists doesn't mean we should be using it. That maybe it needs more work or support, or maybe it's just not the best measure after all. And that's okay. We learn again as we go. So
Mhm.
I think that's a wise thing to think about.
Yeah. It's hard because, there are certain things you just kind of do all the time, but maybe, you have to change. You have to change with the times.
Agreed. Agreed. No, it's good to if I think what as a clinician who's a busy clinician will say, even if you don't change everything, if you go to a course and you're like, oh my gosh, there's like 20 things I should be doing differently, just start with one a week. It's kind of like why, like, okay, you don't have to necessarily. I mean, if something major, then obviously you should change that sooner. But maybe a slight adjustment on the way you teach an exercise. If that's too overwhelming, I think some clinicians get overwhelmed, and that can make them hesitate to make any changes. So I think instead of just walking away feeling overwhelmed, it's good to kind of just climbing up the mountain one step at a time. Let me just every third patient I'll try either the FEIS or the ABC or something like that. Make little mini goals for yourself. This is probably some sort of advice they've given to like starting new exercise in the new year or something. It sounds like, but it seems like it could work. All right, looking at the visual vertigo analog scale, that one I was familiar with as well, but I'm interested specifically in, again, what kinds of patients, something that they might say in their history that kind of tips you off that this could be valuable to use with an individual.
Can't go into the grocery store easily. The floor and the casino bother me. They'll talk about emotion. I think that Elizabeth Dannenbaum's scale is really powerful. We've tried. We actually. I don't know whether Dr. Hoppus will be able to finish the paper as it's under its second or under revision, and I haven't seen it for a while, but she knows that it's on her list.
It's out there.
What we did was, it's so hard. There's so many other things going on in life, but what we did was we took her scale and we added a few other items, and then we did factor analysis because we got about 200 people, 200 people with vestibular disorders, and I think we captured maybe 100 controls, and wanted to see if we could make it any better. And we think the version we have is slightly better than what she originally came up with, and it will hopefully get it published. So it would be a kind of a revised version. But this test is wonderful. it really gives you an idea of for example, if somebody scores really high on this or checks fairly high there on the
Mm-hmm.
analog, you better stay away from habituation exercises initially. You're going to make them sick as a dog. They're
Don't
going to
be
get nauseous.
mean.
Yeah, so it really is a red flag to you to like, man, they do have these problems, and maybe you think you need to talk to your local neurologist or internist
Mm,
to see if you can kind of complement your care with some drug management because they need to suppress their symptoms.
for sure, for sure. And I think that's something that some clinicians, I would at least say ones that are maybe have less opportunity for mentorship or something, they, think habituation means, oh, this bothers you? Okay, let's bother you. And it is true, but like you're saying, if just staring at the thing that bothers me the most made me better, I would probably already be better, right? So, like, the idea of kind of this graded exposure, I think Dr. Pavlo, if I have that correct, has some work on this that really, and I got to hear her speak at the International Vestibular Conference in 2018, and she spoke on the idea of what habituation really should look like, right? Which is this kind of more pre-medicate perhaps if you need to, or kind of see if this person needs migraine intervention that's maybe never had any before you start just saying, here, let's make you bothered. And then if you are going to start to try to desensitize or, whatever you want to kind of terms you want to use there, that you do it in a very graded way, that they have, a limited amount of time. You might start with just 10 or 30 seconds, something really light on the duration, and the pattern is not the worst one, but it's something that's, they're like, oh, I noticed that a little bit, right? That's what we want to hear, like a little bit. And then hopefully a little bit turns into, oh, this doesn't bother me anymore. And then you can go on. Is that having a right interpretation of habituation as you would define it?
100%. Yep, you got it.
Okay, good. That's what I try to do. I think hopefully the clinicians out there either do it wrong a little bit and learn the hard way and don't do that anymore. Hopefully they don't just keep persisting. But it's a nice opportunity here to emphasize, what habituation really should look like, and not just how bad can I make my patient feel, and that'll make them better.
No, then they don't come back when you make them that bad. Yeah.
Exactly. Yes, either they don't come back.
I learned the hard way that.
Did you? Well, you didn't have nearly the luxury of as much literature and expertise before you in this area, I would say. So understandable for sure. But yes, hopefully the clinicians out there that are newer or maybe have not done a lot of habituation can kind of glean this little nugget here and be
Yeah.
gentle, be kind.
Learn from the error of my ways. Yes.
And many out there, not just you, for sure. All with the goal of getting our patients better, of course. But yes, that is a good pearl. All right. So another assessment tool that this patient filled out was the life space assessment. And I'm really interested in this one. So for this one, first of all, again, I like to ask, do you see the value, kind of, what sort of patients or particular, maybe not diagnosis here, but more like certain jobs they have or a lifestyle, or, what kind of tips you off that could be valuable for someone?
Well, its value to me is that I learn what they're really doing and where
Mm,
they go. There will be GPS sensors down the road, and people are using those now for some of the studies, but this is so easy. You just have them fill out a piece of paper. And we did validate this. Kifa actually published the paper in JNPT about 2 or 3 years ago about the use of life space in people with vestibular disorders. It was originally developed for older adults. What are older adults doing? So, and where are they going? Do they come into the clinic and look pretty good, but then do they just stay in their apartment and they never
mm,
leave it?
mm-hmm,
That's what we really need to know. How often do you do things? Do you actually get out of the house? And you get a better sense, at least I do when I have them fill out this questionnaire. I get a much better sense of how active they really are in life, versus, yeah, they look pretty good when they come in the clinic. So there's kind of I heard somebody talk about this recently. They talk about capacity versus like what you really do. So your capacity, maybe you can do all these things, but if you don't do them, then are we really as physical therapists doing a very good job with
mm,
our patients? I'd
mm-hmm.
have to say no. I think we really need to watch them carefully and in the clinic, but also have a much better sense of what they truly do in their homes.
Right, right. And I think that the pandemic is probably not a great. We might have all scored pretty low for a while on
Oh,
this
oh,
one.
yeah, I think we'd all be in big trouble now.
We'd all look like we were homebound because we were.
Yeah.
But
Well,
but hope
this was done pre-pandemic, let me validate, just so you know.
that's good. It's valid for pre-pandemic, and I think that going forward, people are getting into the community again in safe ways, with some modifications and safe measures. So I think this could be more helpful. But even if it's showing, somebody's not getting out as much, it is good to see the reasons why, right? So that's kind of thinking about barriers, right? So one could be, I'm afraid of getting COVID, fair enough. But another could be, well, the person that I used to go with, it got COVID and is really sick, or, kind of the changes that people have experienced in the last couple of years as far as social isolation and access to things like transportation. Um, I think there's some research being done on this. Holly Roberts at CSM was talking to me about, kind of physical activity levels and had they changed or not for people, during the pandemic and what that looked like as they reported it. So it's definitely going to be an ongoing, I think, opportunity for us to look at, kind of what kind of opportunities for patients who maybe had a barrier could we create something different opportunities for them. So yeah, this is a good one. All right, I like it. Moving on, the post-concussion symptom scale. So this scale I was familiar with, but I think it deserves a little conversation. So the name implies you would only give this to patients that have had a concussion. Is that in your estimate
Oh,
true?
that's been validated for that. I used it anyway.
Ah, okay.
He behaves like he had a concussion, and I'm not the only one who said that. Even in the Department of State and some of the documents, they 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 report that they look like they've had a mild head injury, and I
Mm-hmm.
would agree based on the symptoms, and that's who this is designed for. So that's why we went ahead and used it, and he did have symptoms on the post concussion symptom scale, and there's other ones that are out there, the River Mead. There's lots of
Mm-hmm.
others.
Mm-hmm.
They all are very similar, and they all are very powerful measures.
Got it. Very helpful. And so this could be, I mean, if someone scores a certain way on this, it doesn't mean that they've definitely, like if you had somebody who you didn't know if they'd had a concussion or not, this isn't some sort of like, oh, this definitely means they had one. But if you're seeing some scoring that looks like people with concussion, that certainly is kind of something to note. Would you agree on that?
Absolutely. Right. And you can, what I like about it is these measures are so easy to score. You
Mm-hmm.
get a total score and you can look at change over time. So I find them extremely valuable as a clinician.
Awesome. No, that's a very good insight. Put that in your toolbox, everybody, if you don't have it already. All right. So next up is the clinical profile screening tool. So I was kind of trying to take a look at what I could find online about it, and I'm definitely interested in your insight. So this also is not specific to concussion per se. Is that correct? What is the kind of history of this tool, if you know?
It is. So Dr. Contos and his team here at the University of Pittsburgh Medical Center developed this, and it's to look at your clinical profile related to concussion.
Okay.
What they and other groups around the world have been talking about is that people have different symptom profiles.
Hmm.
And what you need to do is identify which symptom profile they have problems with and then get them care in those areas. So it's again moving towards that personalized medicine. We don't treat all people with concussion the same way. And what I was interested in this person with directed energy exposure was if he had any of the symptoms that belong to any of these profiles.
Got it, which I'm guessing he did.
Mhm.
Right?
He did. Yes.
Yes. And yeah, this is very helpful for students, I find, although I would actually say any clinician. because categories could be helpful, right? So like, okay, let me look at the anxiety mood box. Is there something in there? And if so, what might help with that, and knowing there's overlap. So I don't know if you'll agree, but I have found that patients who have vestibular and ocular issues, that if we work on those, sometimes the cognitive, without me specifically trying to work on cognitive, improves. Is that something you find as well?
Absolutely, and you're absolutely right that there's overlap between these. But on the other hand, what they're trying to do is get you to the right clinician. So if you score really high in migraine, maybe you better see a neurologist who specializes in migraine. Or if you're having trouble with sleep, then maybe you need to see a sleep
Mm-hmm.
neurologist or an
Mm-hmm.
ENT. So I think it can help get again the person the right care that they need so that they don't end up with significant chronic symptoms.
Excellent. This is ringing a bell to some earlier measures. I like it. All right. The revised convergence insufficiency symptom survey. So the article does discuss a little bit about why this was chosen and kind of its kind of typical application with young people, if I understood that correctly. Do you want to speak a little more to this?
Yeah, it has been validated in adults now. The idea is that there's more and more data that suggests that people who have difficulty with vergence, especially after a concussion, take longer to get better.
Mm-hmm.
That's been shown by McMaster in Philadelphia. It's been shown by others. Some basic scientists too have been studying this recently. And this test is a pretty quick screen to give you an idea of what are some of the common things that can bother somebody if they in fact do have problems with vergence. And it's pretty insightful, I think. And if you've got somebody who's got a poor vergence score, when you actually go to measure it, I would suggest you actually have them fill this out, and then you can look at whether what you're doing is actually influencing how they feel.
Mm-hmm. Mm-hmm. And is there a point where, because I know physical therapists often work on convergence in a variety of ways, and some debate what are the best ways to work on convergence? Are pencil push-ups good or bad? Um, if you see someone with significant convergence issues, is there a point where you definitely refer to someone in particular to consider additional medical assessment or vision therapy, or what kind of is your thought on that?
Well, convergence spasm always gets sent out because there's nothing that PTs can do for that. But convergence insufficiency, and if it's really bad, yeah, of course I'm going to get some help. So if they're 12, 14 centimeters or more, that's I'm going to get somebody that knows a heck of a lot more than me to manage them. And some of these computerized programs that some of the neuro-optometrists are using have been shown to be effective with changing people's vergence. But doing pencil push-ups, rock strings, some of these other kinds of things that you can do have also been shown to be helpful. So if it's not a what I consider not a bad problem, I'll certainly try to help them. And if it's more than that, then I clearly want to refer out and get some help.
For the
But I
convert.
don't typically send them to the neuro ophthalmologist because
Mm-hmm.
they don't know what to do with these people, and it's a wasted referral.
That's a good point. I was just going to
A
ask
lot
you.
of
You're
money
reading
and a
my
lot of
mind.
time.
People don't always know who to refer to. So neurooptometrists would be your number one. And is that true for the spasm as well as?
No, for the spasm, you find the MD.
Mm-hmm.
That's 100% go to the MD.
Okay.
Yeah, that's because they're probably going to need, well, they'll do very sophisticated testing, but they're also going to give them the right drug to help with the convergent spasm.
Perfect. All right. That'll be very helpful for some folk out there. And I know sometimes it's difficult where someone lives. They may not have close access to some of these specialists, but, we do our best, whenever possible. Luckily, some of the time, it's not like they need to see the person every week, right? So it might be worth that trip to see if they're right.
Well, it's all about telehealth now. You
Mm,
know, people need to use that telehealth card that they can be treated through telehealth even if they live far away. And so, for anybody who's listening who lives in a rural community, I would strongly suggest that you continue to use that resource because practitioners will see them from afar.
Absolutely. No, that is an excellent point. All right, moving on to the Santa Barbara sense of direction scale. Any insight as to kind of which patients pop out in your mind as someone you might specifically try this with?
Well, we're learning. We've got I think about 100 of 100 cases that we've collected with the Santa Barbara. Um, and my PhD student is now working on writing that up. It's been used with persons with Alzheimer's disease, some cognitive decline by Yuri Agarwal, who are dizzy. It also, we've tried it, and certainly it would work with people with bilateral loss because we know that there's damage to the hippocampus. And with that, they have significant problems with direction, changes
Mm-hmm.
of direction, and kind of remembering spatial skills. So we know that happens. Um, we didn't see much, and they didn't. There were very few, if any, that had BPPV. So I'm not sure that the test is as sensitive as I would have liked. I can tell you that I had him fill it out as he would have before he had the problem and after, and that's what we asked all of the patients in our cohort to do. And we so far we've got a story. We're going to write it up, but it's not in all people. You have to wait for the rest of the story for the publication.
Oh, you're
But we
making
did
us
find,
excited.
yeah, we did find something that was very interesting, and we did something very Jeff Stobbish to figure that out. And we are clearly yeah, because we put a ton of time into the use of this test with people with vestibular disorders. So Faye will have, I think, a very interesting story soon for you.
Well, some of us are never been good at directions, so I don't think I would score badly now. That's why I run out and back. I don't go a circle when I run. I just go one way, turn around, come right back the same way.
But see, that's also why we asked everybody how they would have had it before their vestibular
Before.
disorder
Mm-hmm.
and after. So we have everybody do it. So for people like you who don't have a good sense of direction, that maybe it won't change.
Probably not.
If I have a good sense of direction, and if it changed, you'd say, "Oh, she definitely got worse."
That's good. That's helpful.
Mhm.
This one seemed possibly military specific. I wasn't sure. The spatial
It is.
perception test. Is that correct?
It is.
Just
Oh
okay.
yeah, this is what you give the pilots so that they can flip them upside down. Do they know where the instruments are? Can they read them? And he was a certified pilot before,
Mm-hmm.
um, and and we actually had him. He took the exact same test that he had taken about 10 or 15 years earlier. So it's hard to say he didn't do as well, but he was older too, so it's kind of hard. But he really wanted to know on this test if he was different, and proceeded to move on that. So he provided me with the data on this test.
Very interesting. I won't probably give this one out in clinic though.
No, no, you and I can't do this one.
Perfect. All right. So a couple other ones. We had the brief illness perception questionnaire. Can you talk about that just briefly?
Yeah, so that one Jeff Staub had used in the study with 3PD, and there has always been talk about is this a psychiatric illness, this directed energy thing, or is this a physiologic thing? And the brief illness perception questionnaire, there were scores available for people with 3PD, so I could compare, and his scores were nowhere near what people with 3PD had.
Very helpful. Got it. All right. And how about the migraine disability assessment?
Yeah, that's out of the University of South Southern, no wait, San Francisco. Yeah, uh, UCSF. And it's a really neat migraine questionnaire.
Mm-hmm.
So I wanted to see if he met the criteria for that, and it's a good questionnaire. You can look at it online if you go to the UCSF ENT department or
Mm-hmm.
neurology. It's one of those two.
Mm-hmm. How do you see that as being related or unrelated to somebody on fitting the Baronet criteria for migraine or vestibular migraine?
Well, the Marinate criteria are very specific to meet the criteria. This is really what bothers you if you have a
Mm,
migraine. So it's a very different kind of questionnaire. The criteria are very you have to have this many episodes, you've got to have photophobia, phonophobia this many times in this period. So it's very prescriptive. This questionnaire is, how much does it bother you? So for me, it's a nice questionnaire.
very nice. Good differential there. And then the neurobehavioral symptom inventory. Can you talk about that briefly as well?
I thought that's the one that we just did, but I
Oh,
can't remember. I
there's
think
a
we
lot of
just
them.
talked. There are, yeah. So let's skip that one.
Sounds good. All right. So, in conclusions, I think it was very clearly pointed out that interdisciplinary rehab was recommended, although it's not clear what interventions are optimal for patients in this group, although kind of comparison to concussion again was made as far as how you might kind of try to direct care. And, that again, the MRI findings not conclusive in this case, so we'll continue to monitor the other patients and see if we notice any kind of patterns, I suppose. Um,
Mhm.
there was kind of discussion around, is this similar or different to 3PD? You've addressed that a few times now during the conversation. It doesn't really seem like it was a great fit for a pure 3PD diagnosis. Vestibular migraine, there's obviously some overlap, but it was interesting to me that according to the American Academy of Family Physicians, most people would have migraine earlier, so didn't exactly fit in the sense that his first kind of issues were at 43. So something to think about there. Um, and again, those recommendations to kind of start collecting data formally, which you've mentioned, and that's great that they're going to go forward with that. And then kind of really treatment strategy should fit presentation and not mechanism of injury. I think we can all agree on that as well. Um, so I think that just continuing to study this group was definitely on the plan. um,
Mhm.
and hopefully we can provide great care for these patients. So we're ready to go into our questions for the last couple minutes here. So let's go
Can I
to,
just say one thing? I
yeah.
wanted to really thank him for allowing me to
Mm.
have access to all of his records, and he was very kind to do that because he puts forth great effort to share with others to try and help himself and others.
It's always appreciated when a patient will do that for sure. So I agree. Very grateful. So that allows us to do better, right?
Mhm.
All right. So as we get into our questions here, one question that we have from our group is such an interesting case. Oh, thank you. That's not really a question. Excellent. Catherine Strauss says, do some digging. Many have unreported concussion or momentary loss of consciousness that may contribute to their condition. This would explain why they don't adapt or recover spontaneously. Kind of not really a question, but interesting. Interesting. I always like when people have some kind of additional insights. So, the question I had, actually, while we see if anyone else puts in a true question, um, are you aware of any patients who have not been government employees but have reported possible directed energy exposure?
I am not right now, but most of that is classified.
Understood. Understood. Yes, it's interesting because I actually had one patient um, who had concerns about that, and she thought perhaps her neighbor was directing. It was after the incident, so I'm not sure
Mhm.
if it was just. I'm not saying it wasn't what happened, but it seemed like it could have been a fear-based situation because I think when people hear about something in the news, sometimes, it becomes something that they worry about happening to them.
Hmm.
Her findings, I mean, I did not have the study to go off of, but um, to me were not consistent. They did not look like a concussion, I'll say, and they did not have any other kind of specific vestibular findings. But we did some balance work and some kind of just just kind of gentle motion and things to address some dizziness complaints, and she did well. So um, again, I don't necessarily have to have a definite cause of injury to help someone get better, right? So that's encouraging.
Hmm.
Here's a question. What role do you see? You mentioned the magnesium for migraine. Do you think that migraine or riboflavin or any other nutritional elements are important for people with vestibular issues in general, migraine specifically, concussion? What is your knowledge on the role of nutrition?
Oh, there's no doubt. There's some randomized trials that are out there that talk at least about magnesium, and I think riboflavin too, but I don't remember. Um, that suggests that they can help with the headache. So you're 100% right. Now, I am always a little bit strange about telling patients. I'll tell people that this might help. I'll tell them what has been shown in the literature, and then I always say you might want to check with your physician because
Mm-hmm.
I'm not supposed to prescribe medicine. I'm hoping in the U.S. that'll change. It's already changed in Australia. It's already changed in the U.K. The advanced practice clinicians are allowed to prescribe certain medicines. So I'm hoping that we'll finally get moving here in the United States and make that happen because I feel fully competent to be able to do things like that.
Right. And I never feel badly about giving what I'd call over the counter type advice, like, you should be eating healthy. Are you eating your fruits and vegetables? Obviously, check with your doctor on what you're eating. Avoid anything that would be contraindicated if you have a certain medication. You can't have grapefruit or something. But like in general, you know, sometimes you're the only person for whatever reason that has mentioned nutrition to them in my experience, and I have had patients who kind of took it to heart, and maybe they just needed that little reminder or bump to maybe make some healthy choices. So we are getting a question here that's related. What about vitamin D deficiency and recurrent vertigo?
Well, there's 50,000 studies at least about BPPV, and even the latest systematic review seems to suggest, and that came out a couple weeks ago,
Mm-hmm.
uh, that that it can potentially, for recurrent vertigo from BPPV, decrease the incidence of recurrent. So yes, there's in my mind, I didn't believe it for years because older adults have vitamin D deficiency, older adults get BPPV. But the randomized trial that was done by Kim and colleagues out of South Korea definitely
Mm-hmm.
suggests that there's a relationship.
Absolutely. And I'm not aware. The question also asks, what dosage is recommended?
I have that right about this level on the left of my desk at work. So I can give that to you later and you can post it, but
Perfect.
that's exactly where it is. And it's in the Kim paper,
Mm-hmm.
and I don't want to give you the wrong number
Fair
unless
enough.
you remember.
I
It's all
don't
yours.
remember it offhand either, but yeah, we'll definitely put that up for everyone later and answer
Sure.
that question in full. That's perfect.
Hmm.
Well, I know we're a little over time. It's so difficult because you're so interesting, so I apologize. But I hope everyone got quite a bit out of this conversation, and I really appreciate you taking the time to speak to us about this paper and about your excellent work. And so I thank you.
And again, it's only written because he was wonderful. So I thank him.
Absolutely. Gratitude to the patients first and foremost. I'm with you there. So, all
So it's
right.
a pleasure.
Wonderful. Well, thank you again. And thank you, everyone who has been watching or who will watch in the future. We always get a lot of post airing views, but we had over 150 people register for this event, which is the most we've ever had. So, for our journal club. So, thank you for that as well. And we wish everyone a good evening and keep doing your good work.
Thank you. It's a pleasure.
Okay, you're offline.